A growing body of scientific literature is drawing attention to a disturbing link between liver fibrosis, even in its subclinical stages, and the elevated risk of cerebrovascular events, including various forms of stroke. Most concerning, however, is the fact that this elevated risk persists even in individuals with no previous history of cardiovascular disease. In a time when stroke prevention efforts largely target individuals with known cardiac risk factors, this data forces a reevaluation of how we identify and monitor at-risk populations. The results of this extensive analysis suggest we may be overlooking a silent yet significant threat that originates not in the heart, but in the liver. The study, conducted using data from nearly 380,000 participants in a UK biobank, is among the most comprehensive of its kind. The cohort consisted of individuals with an average age of 56.2 years, none of whom had previously suffered a stroke or been diagnosed with coronary artery disease. And yet, those showing signs of advanced liver fibrosis, as assessed by the Fibrosis 4 Index, FIB4, experienced dramatically higher rates of stroke-related outcomes over a follow-up period of nearly 13 years. Individuals with a FIB4 score above 2.67, suggestive of progressive fibrogenesis, were almost twice as likely to suffer ischemic strokes and even more likely to suffer hemorrhagic strokes, such as intracerebral or subarachnoid bleeding. Most grimly, their overall risk of death was significantly elevated, with hazard ratios well above 2.0 across several categories. These findings are not just statistically significant, they are clinically alarming. It implies that thousands, perhaps millions, of individuals who currently appear cardiovascularly healthy may be harboring a hidden predisposition to life-threatening brain events. Liver fibrosis, typically linked with chronic alcohol consumption, fatty liver disease, or hepatitis, is often asymptomatic in early stages and rarely triggers cardiovascular screenings. This research indicates that by the time liver fibrosis becomes detectable through non-invasive markers like FIB4 or the AST to platelet ratio index, APRI, the cerebrovascular risks are already sharply elevated. Particularly unsettling is the strength of association between liver fibrosis and hemorrhagic stroke types, intracerebral hemorrhage and subarachnoid bleeding. These are among the most lethal forms of stroke, frequently resulting in sudden death or irreversible neurological damage. The hazard ratios observed for these outcomes were well above 3.0, marking a risk level that few clinicians would ever tolerate if it were associated with, say, elevated blood pressure or cholesterol levels. And yet, because liver fibrosis has not traditionally been framed as a cardiovascular risk factor, it remains largely outside the scope of stroke prevention protocols. Another issue of concern is that the traditional assumption, no cardiovascular history equals low stroke risk, is now demonstrably flawed. The data dismantle this presumption by showing that liver pathology, even in isolation, is capable of precipitating fatal cerebrovascular events. If current screening protocols continue to ignore liver health, patients may only discover their elevated risk when it is too late, after a stroke, or worse, after sudden death from a hemorrhage. The authors rightfully highlight the urgent need to incorporate non-invasive liver fibrosis indices into regular preventive health assessments, especially for individuals with metabolic risk factors or elevated liver enzymes. Moreover, the study raises questions about the systemic neglect of liver health in broader public health strategies. Fatty liver disease and liver fibrosis are on the rise globally, driven by obesity, poor diet, alcohol misuse, and sedentary lifestyles. Yet public awareness remains limited, and most screening efforts are either reactive or entirely absent. If liver fibrosis is silently increasing the likelihood of fatal strokes in otherwise asymptomatic individuals, then the global burden of neurological disability and premature mortality may be far higher than estimated. Equally troubling is how this data affects clinical decision-making. Physicians may be reassured by normal cardiovascular markers while overlooking elevated FIB4 or APRI scores, thus missing opportunities for early intervention. Conversely, patients with liver disease may not be adequately counseled about their risk of stroke nor monitored for warning signs. This gap in care highlights a systemic blind spot in medicine, the compartmentalization of organ systems, as if the brain, liver, and heart are not intimately connected in the overall architecture of human health. In conclusion, The findings of this study should serve as a wake-up call. Liver fibrosis is not just a hepatic issue. It is a systemic warning of vascular vulnerability, one that significantly increases the risk of stroke and premature death, even in individuals without traditional cardiovascular risk factors. Ignoring this connection may prove fatal for thousands of people who could otherwise be spared with timely screening and intervention. Public health policy, clinical guidelines, and routine medical practice must evolve to reflect this newly understood axis between liver pathology and brain events. Until then, we may continue to underestimate one of the most silent and deadly threats to cerebral health.